Welcome to all the participants. I'm very glad to have you guys all meet with me tonight so I can share with you some of my experience with treating rotator cuff patients and particularly with dry needling. I'm going to start my presentation in a second, so we'll share the screen with you. Please don't forget that at the bottom of your screens, there is a Q&A button. You can all the way through the webinar put your questions on the Q&A, and we'll stop every so often to check on those so that we've got everything nice and clear. All right, there's no such thing as a bad question. Ask what's on your heart and we'll do our best to answer them. All right, so without further ado, I'm going to get going with the screen presentation now. If you have a look on your screens there, you'll see that we've titled tonight's lecture, An Approach to the Treatment of the Rotator Cuff Needling. Okay, so let's just get the right panel over there for you and we'll play that. All right then, so what I intend doing tonight is having a look at the problem of a rotator cuff syndrome, what it is, why it's so difficult to treat, and then understanding what the actual causes are. We're going to have a look then at some ideas on how to develop a therapeutic plan to address that. I'm going to use a particular published paper by some Spanish folk, Arias Buria et al. 2017, to inform some of the things that we're doing around that. And then, because we want to make it as practical as possible, we're going to do a practical demonstration on one of my patients who I've been seeing for his shoulder. So there'll be a bit of theory, there'll be a bit of practical stuff, and there'll be some needling involved. So if you've got no experience of needling, you'll be seeing it tonight. Don't forget to turn up the volume when the needling starts. What is this thing? What is this thing called a rotator cuff syndrome? See, the problem here is that we've got so many terms to describe the same problem. A bursitis, subacromial pain, rotator cuff related shoulder pain, tendinopathies, even frozen shoulders. So many different terms to describe what is essentially the same clinical phenomenon. And I say the same because even though there may be elements of tendinopathy, there may be elements of a bursitis, sometimes inflammation, sometimes frank tears of that area, they all share one common pathological element, and that is a load intolerance, What we really want to be doing with these patients is to try and get them to be able to individually tolerate the loads that we place on them. To be sure, it's a multifactorial problem. You may have psychological complications, metabolic complications, psychological complications, and even some visceral complications such as the liver, the heart, all referring pain to the shoulder. But the bottom line, when it comes to physiotherapy treatment of the shoulder, we're going to see load management complications. These are individualized load management. So my shoulder can bear a certain amount of stress. Yours may be different. Our patients are different again. Our therapeutic approaches must be individualized to treat these patients. So when we're having a look at this, we want to be absolutely sure that we have a solution as well. So therapeutically, we want to fix the load tolerance. Doesn't matter how old you are, young, old, it's all the same. Get your patients stronger. They need strength, they need power, and they need endurance. Stretching, not so much. Rest, not so much. Shoulders respond to load. And that's just not my opinion. In the new systematic review that Peter's published this year, you will see that their strong recommendation is made in favor of exercise therapy for patients with subacromial shoulder pain. So yeah, exercise is going to be the cornerstone of how you're going to treat your patients. Now, the exercise therapy we're talking about, it's difficult to say what's the best exercise. There is no best exercise. There's no best exercise system even. There are only principles that work for all shoulder patients. Now, what's going to happen with those shoulder patients? It must be an individualized program, something relevant to the patient, something that they can do. Not out of a textbook necessarily, something that they can do. Both in the clinic, you can make it harder in the clinic, but something at home that they can regularly do every second day to make sure their progress is up to scratch. I very rarely prescribe more than 3 exercises at a time because patients just don't do them, all right? Individualized, few exercise, targeted. what kind of exercise. It has to be resistance-based. If we don't overload the tissues and allow them to rest and heal, you will not make the progress that you should be doing. Patients often need to hear this, but they can tolerate up to a 6 out of 10 pain scale during exercise. That's okay. It doesn't mean they're breaking. It doesn't mean you're doing damage. It's completely okay to have pain during exercise and even some pain after. The pain that's not okay is pain 24 hours later. Then you really have overdone the overloading and you have to back off that a bit. Sadly, it's going to take 2 to 3 months of strengthening to get your patients right. There is no magic bullet, unfortunately. 8 to 12 weeks, that's what we've got to do for these patients. If we have a look at the training parameters that we want to give each of these patients, I'll put a couple of ideas here because often we get lost in the fog of all of these things. So you can see down on the y-axis, there's strength, there's power, there's endurance, and across the x at the top there, the sets, reps, and speed. These are really practical tips that you can give to your patients. Type them out on the pages that you give them for their exercises so they know exactly what to do. Let's say the easiest one is going to be strength. You want to give your patients 2 to 4 sets of these exercises to make sure they're working quite hard. Non-consecutive days, okay, so skip a day in between because the tissues need time to rest and to get the hypertrophic response going. Each of those sets, how many reps? Now, physios don't have access to fancy machines and 1 rep max calculations. What's clinically the most helpful for me is to say that on the first assessment, see how many of an exercise the patient can do. Let's say they can manage. Use that number, 8, do 70 to 80% of that 8, and do reps of that number. So 2 to 4 sets of 70 to 80% of their 1 set max. Is that simple? Yeah. That way they get encouraged, they can keep going. For the speed, go slow, emphasize control. So for just forward strength, every second day, 2 to 4 sets, 70 to 80% of what they can do in 1 set max. That's a little different when you want power. Power will come later in the treatment, okay, when you're getting them back to sport, back to active physical jobs. There you want to add the element of speed in as well. Fast, explosive motion. Here you're going to do fewer reps with higher load. Again, 2 to 4 sets of non-consecutive days. And then once you've got the strength, even further earlier in the process as well. But here, for endurance, keep them at a steady pace, lower load, higher reps, between 10 and 25. Okay. Get all 3 of those elements in your exercise putters. The paper we're going to look at tonight used not just exercise therapy, but dry needling therapy. So best we say a thing or two about what is this dry needling business. If you were at our previous webinar, you'd have heard about the evidence that underpins the dry needling technique. But just to recap, with dry needling, that's the indicator of success. So why would you want to do that? When you diagnose a trigger point, it'll be a tender nodule within a taut band that gives the patient their known pain. Those are easy. But remember that there are mechanical complications to trigger points as well. They decrease the range of motion of a joint, makes you feel stiffer. They decrease the strength of the muscles around a joint, so you feel weak. And they decrease your proprioception. So your motor control is not what it should be. Not because they're weak, not because they're stiff, not because they're uncoordinated, but because they have trigger points. Trigger points change the contractility and extensibility of your tissues. So you need to address them as part of your exercise program. So 2 legs then to this paper we're going to look at, the exercise and the dry needling. Now this paper that I've chosen to look at, Spanish paper, is a randomized control study which looked at 2 groups, one which received targeted rotator cuff exercise only, and another group which received targeted exercises with an add-on of dry needling. Now, you won't have read this paper yet, but we can share it with you as part of the show notes. I'll walk you through it and take out some salient points to show where I think they've gone right, maybe when they've gone wrong, and then we'll take those points and use them on our patient, when we'll see later. So if we have a look at the breakdown of the paper just over here, they took 60 consecutive patients who came into the clinic, excluded some for the reasons that are there, but they didn't have trigger points, some of them, and then randomized them into two groups. Now, this study has been powered for 90% at a p level of 0.05. So what that means is that if they've got group sizes of at least 25 each, the results will be statistically significant. They have the power to show you what you want to see. In the study, they bumped that 21 to 25 to take care of anybody that dropped out of the study. So they had a good scientific rigor over there, using an intention to treat analysis to take care of anybody who did actually drop out. If we go back to the slide where it shows you the breakdown of the study, you can see those two groups were there, and the description of the treatments we'll go through in a second. All right, so they had two groups. One is needling, one is exercise. In the exercise-only group, they used exercises for the supraspinatus muscle, infraspinatus muscle, and some of the scapular stabilizer muscles. They were using 8 to 12 reps, so going more for a strength approach, and focusing on the eccentric rather than concentric phases to bias the strength gains. So good idea, well done for them. They taught that to the patient in the first session and then monitored it once a week for the next 4 weeks, 5 sessions in total. The patients did the homework twice a day for 5 weeks. So that's more than I would give them, all right? But clearly it worked for them. They were phone monitored to ensure between a 90 and 95% adherence. Nothing like if your physio phoning you every day to see, have you done your homework? That was the exercise group. Exercise plus needling group, they did exactly the same thing. Those 3 exercises, biasing those 3 well-known culprits for shoulder pain. But in this group, they added just 2 needling sessions. That's at session 2 and at session 4. They did trigger point needling, not tendon needling. Important. They used a particular kind of needle, Novosan, 40 millimeters long, and using a fast in, fast out technique to get those myofascial twitches. The treatment stopped when the twitches stopped, which they averaged out to about 15 minutes duration. So that's the broad bones of the study. They wanted to see, do you get anything extra from adding dry needling to exercises only? Now, just a word about the needling of the muscle only. There is some not controversy, but interesting discussion in the literature about why don't you just needle a tendon as well? Now, we don't needle tendons, but let's have a look at 2 recently published papers that say, well, why not? The Riggin paper, published in 2019, showed that you do get early healing responses by needling a rat tendon, okay, supraspinatus. Apparently, a rat supraspinatus is very similar to a human supraspinatus. Not sure how many humans are rats, but there you have it. And that showed that even though there was early healing at a 6-week endpoint, there was not much difference. So, like, why needle? Now, you didn't get bad effects, but just didn't get good effects either. Stoichev is an interesting paper. It's a narrative review where they've taken different tendons from different parts of the body and seeing, okay, what does needling do in each of these areas? The paper they identified to deal with shoulders was published by Ra, and they used an ultrasound-guided technique, where in humans this time, they put a 25-gauge needle into the rotator cuff tendons about 20 to 40 times under ultrasound guidance to see what the results were like. Nothing. They compared needling alone to needling with PRP, and there was essentially no difference between the two. So, are we surprised? Not really so much, because the load tolerance depends on the tension generator in the system, which is the muscle. The tendons are just like pulleys. They transfer the force. It's the muscles we want to focus on. So that's what these guys did, focused on the muscle. How about the results? Well, they looked at the worst pain the patients had, looked at the average pain, and then they looked at a functional measure called a DASH, disabilities of shoulder and hand. On this result slide, you can see the dotted line was the exercise-only group, and the straight line was the dry needling group. And over the course of the 1 year, you can see there's essentially no difference between the two lines. They track each other pretty much all the way down. There was no difference in the two groups when they talked about what is their absolute worst pain. How about the average pain? Again, the two lines track each other almost perfectly. So for that subjective measurement of the shoulder problem, the pain, needling, exercise, they show you exactly the same trend. And maybe that's natural history. Maybe that's regression to the mean. I'm not sure. Maybe it's just showing you the effect of exercise on pain. So is there a difference between needling plus exercise or exercise alone? Here comes the DASH slide. If you look at the difference now, wow, the dotted group is exercise only. The solid line is dry needling. And you can see right away, right after the study, there's a big difference between the two groups, like a 20, 30-point difference on the DASH. Remember, the MCID for a DASH score is just over 10 points, nearly 11 points. So that's a big difference. And at all time points, that is maintained right down to 12 months when the pain is almost negligible. No difference in pain, big difference in function. If you're looking at a DASH and you want to see, okay, how successful am I? You can use minimal clinical important differences, but you could also decide, okay, if you're 50% better, that's regarded as a successful treatment. Look here at a 6-month follow-up. Highlighted is the non-successful outcome. Exercise, 10 of the 25 were unsuccessful. Exercise with needles, nobody had less than 50% improvement. That was maintained all the way at 12 months as well. Nobody failed that treatment. While in the exercise group, 4 continued to have problems. In fact, it's more because 2 people dropped out of the exercise study to get cortisone injections. Essentially, they dropped out because they weren't doing well. There was 1 dropout in the needling study, but he had a whiplash injury, so we'll excuse him. So in conclusion, if you look at the RSBRS study, you can see that exercise is effective, absolutely. If you add needling, you get better changes in function, more changes in ADL, even though pain doesn't change. The changes are faster and more effective. So you look like a better therapist if the patient gets better quicker. Those are those 2. So we see from that study, we want to exercise, we want to focus on the strength, the power, and the endurance studies. But because trigger points mimic those changes in load tolerance, we have to reset them too. For me, a fantastic way of doing that is by using dry needling, and that's what we're going to do with our patient demonstration just now. Does anybody have any questions now that they want to ask, just for clarity, before we just change venue and do a patient demonstration? Doc, got any questions there? All right. If there's no questions there, what I want to do is just pause for like 60 seconds while we change and get ready in our clinical room with our patient model. All right, so if you guys, Doc, are you there? We're going to just stop the share there now. All right, Doc, you got there? I've got 1 question at the moment. Asio says, any other modalities along with the dry needling? I like ultrasound. Okay, I don't think that there's any place for using ultrasound therapy in the shoulder. I think in terms of your bang for buck, so it's clinical effectiveness, you get massively more progress by using exercise. Other modalities, there is some evidence for shockwave therapy, but electrotherapy in general, not so much. The gold standard is exercise therapy. All right, so if you'll just give me a second to set up next door with our patient, we'll do a demonstration live. Okay, I'm going to share my screen over here, and we're going to go for one of these. Okay, so there we can see our model. Left to right, right. So here we have a patient who's had a symptomatic left rotator cuff injury. If the patient elevates both his arms at the same time, lift up. Is that about your max pain? All right, so follow his scapula over there. That's about as high as he can lift because pain limits him going further. Go down. All right, so you can see from his scapula that it's downwardly rotated over this side here. So what we're seeing is that the lower fibers of traps, upper fibers of traps aren't rotating the scapula like they should. What we're going to do for this patient is prescribe him 3 exercises which are going to help him, but we're also going to do some needling of the lower fibers of trapezius, the infraspinatus, and in the supraspinous fossa, the supraspinatus. Okay, so if my drawing is terrible, supraspinatus in there, infraspinatus in there, and then the lower fibers of trapezius on the side. What we're going to use is the dry needling station, which we've got set up on the trolley over here, and I'll talk you through what elements are in there as we go. But let's get our model to lie down on your right-hand side. Okay, so here we're going to go and have a look at the infraspinatus needling now. We're going across the muscle fibers to find the most tender nodule on those fibers. So I'm going to get Mark to tell me about what he's feeling again. Are we feeling there? Pressing only, all right. In we go. Right, now come on, tell them all about, there we go. Did you see the jump? It was nice, wasn't it? Jumping away. That's what we want, is little jumps coming out of the tissues. In, out, getting as many of those little jumps as we can. Now, there's no danger to the lung here because the infraspinous fossa is the other side of the needle, so that prevents us from going into the lung. Another jump, beautiful. And you want to get as many of those jumps as you can so the muscle gets reset. Obviously, infraspinatus has a number of different trigger points in it. We'll do a second one just at the top here as well. All the time after those twitches. In we go. Jumping, jumping, jumping. All right, that's infraspinatus. Then the supraspinatus will be the last one we have to have a look at here. Up the top here in the supraspinous fossa. Now again, we're going to be very careful to avoid the lung. So what we do is we make sure the needle doesn't go in towards the infraspinous fossa, but the supraspinous fossa. That means we have to change the angle which we insert the needle at. Instead of just going in a PA direction, we have to go more from superior to inferior. You palpate the borders of the scapula. Make it flat, so we're aiming at the inferior angle of the scapula. Palpate across the muscle fibers to find the most tender nodule, and then insert, taking care not to go anterior to the scapular fossa, supraspinous fossa. There we go. That angle is now going down towards the inferior angle. If I pop the guide tube on for contrast, you can see the angle. And that's about as much as you need to do with the needling part. As long as you get the twitches, you're good to go. So I'm going to get Mark to sit up now, and we'll do that same shoulder flexion to see how that moves. All right. Both arms up, above the head. And I'll get him to do that 3 times before I ask him to tell me what it feels like. We go all the way to touch the ceiling. And then the critical movement for shoulders, of course, is the hand behind back. So try and undo your bra strap. Good. Now we started out with about an L5 movement on that. So that was very good. Last time? Yeah, up, all the way up. See how that scapula is going out nicely now, hey? That's good. Lower fibers of traps is doing a good job. Down to the bra strap. That's grand. That's exactly what we want for our needling. Okay, now in terms of rehabbing the shoulder, we want to do some exercises practically focused that are going to help this patient. What I want to do first of all is because clearly he's quite a strong chap, so we're not going to give him little nothing exercises to do. What we're going to do is we're going to help him to do some load-bearing exercises as well as some TheraBand, hard TheraBand exercises. So first up is going to be his Sharapova exercise. Remember the Sharapova? Against the wall. Okay. So what happens with the Sharapova exercise is it's going to be a combined movement where we're having a look at the flexion, abduction, and external rotation of the shoulders, both together, using a TheraBand. He's going to be against the wall, and we'll make the light look better than that. Okay, so there's a green TheraBand. Now, it's really important that when you get your patients to do their exercises, that they do them accurately using the parameters that you need. We've got him with his elbow parallel to the other side and the wrists parallel to the other side. So he's going to go pushing up and out. There you go. And then the left side, in, up, out. Okay, pushing higher each time you go. Work it down, 3 on the way down. And you can do that left side, then right side, or left, right, doesn't matter. Okay. I thought of giving the patient 3 sets because 3 is quite hard for most patients. How do you feel after 3? Stiff. Stiff, you feel stiff, which is okay. This is a combination exercise, so you're getting those 3 cardinal movements: scapular rotation, external rotation of the glenohumeral joint, flexion of the shoulder. That's a cracker of an exercise once you can do it. Okay, so you can start them without TheraBand and then progress more. Second exercise I want them to do is going to be a standing TheraBand exercise with the lower limb attached, so the rest of the kinetic chain attached. I'm going to get Mark to put the elastic band behind his back, and we're going to go the elastic band around the inferior angle of the scapulae. Okay, so drop your shoulders. I'm going to be that way. He's going to punch forward with his symptomatic hand at the same time that he lunges with the other leg. It's higher grade, okay? You punch with the symptomatic arm while you lunge with the good leg. Go for it. Yes. Okay. Now, as you get good at this, you can get your patients to externally rotate the arm as well. He's getting tired, isn't he? And that's enough, right? Remember how the loading works? We get him to do his maximum and then go back 70% of that to set his number of repetitions. Okay, so we can do 3 of the Sharapovas. He was a bit knackered after 5 of those, so I might give him 4 sets of 4 to practice with that one. And then because we like closed kinetic chain exercises, the third exercise I'll give him is going to be on his hands and knees. We'll put him on the bed for that in a quadruped position. Quadruped. Okay, now when you're doing closed kinetic chain work, okay, it's going to be the standing or the supportive arm that's doing all the work. First of all, we get the patient into a nice lumbar position, so a little bit down there, nice strong position in the back, and you simply ask the patient to lift, flex his non-involved arm. So go forward with the hand. How does the load on this side feel? Yeah, it's there, yeah, and back down. All right, so here we want endurance stuff. So you want to bias him with slow movements longer, all right? 20 to 25 reps if he can handle that many. Up you go again. And down. Mark's a strong guy, and he's still shaking when he's doing this exercise. Very effective. Up you go again, one more. and down. And that's what I would give the patient as his homework exercises. I'll give him no more than 3 exercises at a time, because that's all you need to do. You keep them busy for about 13 minutes or so, 10 to 15 minutes every second day, and they clearly make progress. You want to share a bit about your progress so far?
It's been great. I'm actually glad that I came for treatment. I was initially a bit nervous about the needles, but I'm very happy that we went ahead with it.
All right, so one satisfied customer.